Oh, hey, Chris.
Hey Chuck, how are you?
Great. I am great. How are you?
I'm wonderful. So I had a funny story to tell you. Uh, my kids, for some reason, I think now we're very much like we don't like YouTube for our kids, but they've seen enough stuff where they actually want to record videos of themselves doing stuff and they want me to record videos of them. And at the end, they're like, please check out our channel. And I'm like, whoa, this is kind of weird. And then my daughter, I was home with my daughter and she was having dinner and she's like, take a video of me. She's like, how do you get on the TV? And I'm like, well, she's like, have you been on the TV? I was like, well, yeah, actually I was on the TV. Like, they did like a news segment about a patient that I had a few years ago that had a bad perineal nerve injury. And we did a reconstruction, ended up doing great. So there was, a segment on the local news and I was on there and I was like, you remember when I was on TV? And she's like, no. I was like, okay. I was like, actually, I'm on TV every couple of weeks. And so then I pulled up our upper hand on YouTube, and she was super impressed. So for those of you that listen to us, you can actually watch us if you want to on YouTube and our rapidly expanding YouTube presence.
What an easy way to impress your kids. My kids are not so easily impressed anymore. Um, but that's great. That's great. It would freak me out if my young children were. I mean, even since my kids were young, things have changed so much. My goodness.
Yeah, we're pretty protective of posting images that we don't post images of them on any social media kinds of things, and we try to be very careful about what they're allowed to view. But my parents are not as careful when they're watching the children about what they allow the kids to view. So some of that stuff does leak through, and it's that algorithm's pretty scary, to be honest with you.
For sure. I am two things about for those on YouTube. I'm wearing a St. Louis City SC. So in St. Louis, it's St. Louis City Soccer Club, not FC, not football club. So, but by the time this drops, I hope things have gone well for our soccer team. It was an amazing regular season, and we hope their success continues into the playoffs. I'm geared up with some nice headphones and microphone. You and I seem to alternate, never do this at the same time, but hopefully our audio quality, or at least mine, will be better this time.
Right. Well, I think we do the recording off of your computer, so honestly, you always have the home court advantage on the audio. And today, because I'm rounding, I didn't bring the whole setup, but I do try to use the whole setup when I'm recording from home.
Yeah. So I had a really special event a couple of weeks ago, which is I went to my son's white coat ceremony. And for those of you, I think everyone can imagine what that is. Honestly, I'd never been to a white coat ceremony. We didn't have white coat ceremonies back in the day. And I'm not really into pomp and circumstance. And I was kind of like, okay, I'll definitely be there. I wasn't sure what to expect. It was fantastic.
Well, I mean, that's great. You should include the important detail that your son is a first year medical student, and then maybe
True,
tell
true.
what a white coat ceremony is supposed to be about and why it was so fantastic.
Yeah, so Jake is here at WashU and started med school, I guess, right after Labor Day. Has had a few tests. It is pass fail, but as my wife and I continue to impress upon him, no one wants a pass fail doctor, so don't just study to pass. And yeah, he's loving it. It's just so interesting. It's a very different medical school environment today, and I think the vast majority, if not all of that, is fantastic. In the white coat ceremony, they were basically there was a lot of speakers, which were the dean spoke and the associate dean for education spoke. Great, they were fantastic. There was a guest speaker who was fantastic. I think a couple of things struck me, three things maybe. The first is that
It's
they
the
were
first time you've done three things.
I know
This is
it's
two.
like my brain can't handle more than two. The first thing is they receive their white coats after all the speakers from their coach. So there are coaching groups within the medical school, and I think they looked like there was maybe 10 or 12 kids for each group. And so their coach was up there and gave them their and put their white coat on, which coaching for students, I think it's probably the right approach. People smarter than me have put a lot of thought into this, but if you kind of start early with the wellness and the kind of cerebral aspects of medicine, it can only be a benefit.
Right, absolutely. Yeah, it's a long career. Medical school itself, the days feel very long, but the years tend to fly by. It's kind of like residency in that regard.
And
But
child rearing.
yes, as I'm fully aware, it's funny. I do see my kids getting bigger before my eyes, and then like you're in the weeds on this stuff, and you're like, oh man, it's gonna fly by.
Yeah, it's Talia's favorite statement is the days are long, especially with young kids, but the years are short.
Right, right. Well, so you got to see the ceremony? Yeah, tell me your other things.
Yeah. No, so I got to see the ceremony. I didn't get to sit with Talia because we were only allotted 2 tickets. And so Talia got one, and the girlfriend, Allie, flew in from New York, and so that was great. And so I had to sneak in playing the doctor card. And so that worked out thankfully. So I was able to
Yeah.
get in the room. The room was packed. And so the two other things that were fascinating to me, number one, the diversity of the class is astounding. Like, obviously I knew it was going to be a diverse class. Blew my mind in every way. And it wasn't just ethnic or racial, it was geographic, it was everything. So there certainly were obviously a lot of US kids. There were people from across the world. There were Russians, there were Chinese. I just, in this geopolitical era, I wasn't even sure that was possible, but it definitely is. And so that was just fascinating to me and wonderful. And the second thing was, when I was a medical student, here we go. Chris is like, oh God, here we go. It was keep your head down, speak when spoken to, and the lower the profile, the better. And that was medicine, for many, many years. And medicine's clearly evolving, and I think that is the right word. But it was kind of a joyous occasion. So you'd walk up to get your white coat, you sort of wave at the crowd, maybe take a selfie with your coach, and there'd be some catcalls from I don't know if catcalls is the right expression. There'd be some hooting and hollering from the crowd. It was just a very there wasn't such a serious vibe, even though the messaging from the speakers was serious. So it was a fantastic event.
Generational differences, so to say.
Yes.
Did they have to do the Hippocratic Oath?
They did, I think most, and I don't know what yours was like, 'cause I'm certain that you had a white coat ceremony. I think it's an updated, they wrote their own, Hippocratic oath. Not their own Hippocratic oath. They wrote their own oath, and they stood and they read it. It was fairly long, certainly comprehensive, and really good, really, really good.
That's great. Yeah, no, yes, I did have a white coat ceremony. I still remember it in the sweltering heat of a Miami August in the research quadrangle at the medical campus, getting our coats, which was a nice thing. It wasn't. I don't think my parents came down because it wasn't. Honestly, it wasn't a huge deal to them. But and I didn't realize it was a huge deal. But I remember that ceremony. I also remember my last white coat ceremony was actually during my residency. And this is they no longer do this at HSS because it used to be that you didn't get your long white coat until you were a chief resident. So there was actual white coat ceremony during the residency graduation. So as the chiefs were graduating, they would put long coats on the PGY4s who were still then wearing short coats, which is super interesting because I actually wore a long coat in med school and had to switch to wearing a short coat during residency, internship and residency. And the person that put on my coat was none other than Dr. Marshall Burks, who was our guest about a month ago on the podcast, and is now a very dear friend. So that was my last white coat ceremony experience. But as I learned recently at the HSS alumni meeting, the HSS residents now all wear long coats. So I think that's probably the only orthopedic residency in the country where that was still a vestige of the past.
Yeah, the white coats are really an interesting phenomenon. First of all, I don't wear a white coat almost ever. Like I almost never wear one for a lot of reasons. And the pediatric population, there's always been this sort of built-in excuse that you don't want to scare the kids, and there's some truth to that. I'm not a white coat guy. But there used to be, you could clearly tell the ranks, and at WashU in general surgery, which was hardcore, you were as an intern and as a resident, you always had a short white coat and you wore it 24/7 unless you were in the OR and you hung it on the hook outside the OR to put it immediately on. But the other interesting thing about back in the day was you never wore scrubs outside the operating room. Now we say don't wear scrubs outside the hospital, but back in the day it was white coat and your tie and shirt and tie, and again mostly male, so shirt and tie was appropriate. Things have changed.
Yeah, one last thing about, dress before we move on. I remember as a rotating medical student at what was then the Hospital for Joint Diseases, and is now I think the NYU Langone Orthopedic Hospital. But I was there rotating as a student, and they were very strict. It was, if you were not, like you're saying, in the OR, you had to have a white coat on top of your scrubs, and if you left the floor where the OR was, you had to change. So if you, for example, if you were going to go see a patient between cases, you had to change back into your professional attire and then go see the patient and come back and change back. When they were strict, that was the culture. It set the tone professionally. I don't know if they still do it that way, but maybe a listener could tell us if you're at what was formerly joint diseases. But it's definitely a culture setter, and I think there has been a lot of change in terms of what people expect their physicians to look like. I know there have been surveys about what looks more doctorly, for example. And it's interesting. We had this conversation with partners where like sometimes like you're wearing scrubs and they're like, oh my goodness, did you just take some time out of surgery to come see me? Or are you on your way to surgery? Oh, thank you. Or it's like, why do you look like a slob today? You're wearing your pajamas.
I know. As I think I've said here, COVID changed everything for me because I began putting on scrubs every day when I came to the hospital and then not wearing those scrubs home. And I continue to do that. So I must look like a slob to some. And thankfully most patients seem fine with it. I have had a couple of patients, typically older, comment that I went a little casual in clinic, and I just laugh. The same people usually comment about my beard, so
Yeah,
um,
I used to wear a tie all the time. The tie was a COVID casualty. I still wear a white coat in clinic, and it's uh yeah, I don't know if I'll change that, but I think maybe one day as I develop some grays, I'll change.
yeah, I don't, just to be very clear, because I know there's some younger listeners, I do think appearance and the persona of being a patient's physician matters. And if we dumb it down, so to speak, or bring it down to the lowest common denominator, I think we lose something. And I am acutely aware of that. And I try to make up for my scrubbed attire. But I I still think, even though my practice is not it, I still think it matters. And we can complain about and I'm gonna get on a soapbox for a second, but we can complain about doctors' place in society. But we have to own some of that.
Right.
And it's really is interesting.
Well, I mean, to be honest with you, that's the reason why I wore a white coat and a shirt and tie in clinic is because, especially starting practice, I looked a lot younger, and that is the kind of the credibility aspect. At least you don't want somebody to question your credibility even more if you're not wearing a white coat or you're not looking like you're supposed to. And again, that's some of that's assumptions on our end, and then trying to make sure that we're withholding kind of that place in society. But it is less common for people to ask me how old I am now, although I do love it when people ask me. And then now I take because I used to get pretty defensive about it. And I think I've shared this with some of our trainees. I used to get kind of like, oh, well, I get worked up about it. And I joke about my student loans, and suddenly it was a fine. And then now when they tell me I look young, I'm like, thank you. I've been trying to sleep more. Jokingly say, these nighttime serums are working, whatever it is. So I appreciate it now.
It's true. One more last thing. I love that. One more. No one asked me, because then they think they think they're going to insult me by like saying, "You're old. Are you young enough to be doing this?" Talia was telling me about some TV show. I don't remember the TV show, but it was, and this will resonate with you. But they were in New York City, and they were at a cocktail party, and a bunch of finance bros, and so someone asked another person, "Oh, so what do you do?" And the person says, "Oh, I'm a physician." And she says, "Oh, that's so nice. That's so good of you to be a physician." And it kind of turns away and ignores that physician, because it was just like, there are more important and higher paid people here, which is like, oh my God.
Yeah, yeah, role in society, huh?
Yeah.
So speaking of how great it is to be a physician, we should thank our sponsors at PracticeLink. So the Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join Practice Link for free today at www.practicelink.com/the upper hand.
Is that a
So
backslash or a forward slash? I can't.
that's a backslash, I
I
think.
don't know. I don't know why I haven't thought
If
about
you're
back or forward
watching,
slash. All right, they're tired. The people are tired. They want to get to the meat and potatoes, Chuck. What are we talking about today?
we one theme from the Hand Society meeting, which seemed to be really well received, was around tips for success. And we were fortunate to hear from our partner Marty Boyer, who was the founders lecturer for President Jennifer Wolf, and shared his what he calls his 10 rules, which I wasn't a fellow under Dr. Boyer, but so I have a vague remembrance of some of those rules, but it was a very well received talk. And I was fortunate to participate in a symposium on Saturday, which was excellent. Was not particularly well attended because it was Saturday afternoon, but I thought we were going to talk about I'd like to talk about some of those points.
Yeah, I think it'd be great. One of the one of the Boyer rules of surgery in life is try to take the early flight home, and I think that might have affected your attendance once everybody heard that lecture.
Yes, it probably did. It probably did. So to lay the groundwork for the panel, Don Lalonde organized it, and I was a speaker. Scott Cozen was a speaker. Jim Chang was a speaker, and Tamara Rosenthal was a speaker as well.
Whoa,
So
that is a high power group. So you've got two former Hand Society presidents, one person who is in the presidential line for the Hand Society, and the
and then me.
current treasurer of the Hand Society. So that is a high powered group. And then like the godfather of Wallons moderating the panel. So this should have been the most attended session in the whole darn course.
It's interesting when you plan, well, you're kind, but when you plan these meetings, you always wrestle with, well, if I put something, and I hope this was the thought, if I put something really good later, will people stay? And if you put everything good early and put the less potentially popular symposia and ICLs later, what does that mean? People don't stay. It doesn't matter. Like people just don't stay. They're going to leave when they're going to leave.
Listen, I didn't go to the main meeting this year, but I remember last year I got the coveted 6 a.m. Saturday morning time slot for a research methodology ICL. So I hear you in terms of even though you think it's amazing content, and this may not have been the biggest draw, but people are they're either gonna be there or they're not. So, I'm not as much as your content was probably amazing. Hopefully, well, I guess there was no recording this year, so at least you can distill it for us now.
I'm going to do just that. I'm going to start with a quote, which to me resonated, and I believe it's important. This is by Albert Schweitzer, who was sort of a Renaissance man back in the day and won a Nobel Prize. But he said, success is not the key to happiness. Happiness is the key to success. If you love what you are doing, you will be successful. And I know that resonates with you, and it resonated with me. And I'll say one more thing and then love your thoughts. You know, when I am not happy, it's typically because I've had a challenging patient interaction or outcome, and I tend to really perseverate. That patients who may not have done as well as I hoped or thought, or patients that were unhappy, whether or not I felt like I did everything I could have and should have done for them, I learned from those, but those affect my happiness. And so I think if you do the right stuff, prioritize your patients, success is going to find you. At least that's what I hope and expect. But I would love your thoughts on this general concept.
I don't, yeah, I agree. And I don't think there's a whole lot to elaborate on that, but I think that if, success is how you define it, right? And I think that a lot of us, especially in the pursuit of getting to where you are in terms of medical training, for many of us, it is lots of external measures of success and validation. But then all of a sudden you get into practice, and it is, yes, there are external measures of success, the metrics of some of which would include productivity measures, compensation, those kinds of things. But it seems to be that if you are in the inevitable, relentless pursuit of the RVU, you're not going to be happy. And I think the wonderful thing, as much as you're talking about, the lowly role that physicians sometimes now hold in society, the lovely thing is that our work is intrinsically joyous in many ways, especially I think for those of us that have chosen to be, surgeons. We have a personality that tends to like to see these kinds of outcomes happen pretty quickly. Now, obviously not the case for nerve, but for the vast majority of what we do, you help people on a tangible and substantial and meaningful and measurable way.
Well said. And our therapy colleagues who may be listening, they get a little something more than we do, at least I think. They have in many ways, develop a closer relationship with the patient because of the time invested at therapy sessions, and can really, see more of that progress. You and I get intermittent glimpses at progress and patient success stories, but that's what matters. And again, I really do feel like that if you quote unquote do the right thing, it really does tend to work out. And that sounds easy. It's not always easy. Time and pressures and various things get in the way. And I do think about what you said. I've never been one to write down 5-year, 10-year plans, but if we're talking about career success, that is a really important starting point.
Yeah, and just to touch on your point about the things that our therapy colleagues get out of the relationships, that is, for lack of a better term, that is quite an intimate relationship you have, like with all the physical touch that's typically involved with, somebody who is helping a patient through a recovery, and then like the constant contact and the frequency of that contact. Which it explains why all of our therapists get way more gifts from patients than we do, which it's so funny. Come holiday season, the therapists in our group will come in just like, we got all these cookies. We don't know what to do with them. I was like, I didn't get anything.
Exactly
I
right.
kid. I kid. I kid.
All right. So the assignment for the symposium was to, what to say or not say to patients. And I really like that. I actually wanted to start with what to do. And some of this will sound, like you've heard it 1,000 times. But in a room with a patient, I'm sure you're going to have stuff to add, but I wanted to keep it simple. I always sit down. I say this carefully because it's really important. I'm better at it today than I was 10 years ago. I listen. And sounds cheesy, sounds obvious, but there's a difference between sort of listening or being distracted, and really empathetically listening to patients. It shows. I am way better at that today, and honestly, it's a win for me as well because I do think I connect better.
Yeah, I'm not been a good listener for a long time, and I think that the more you because usually how our minds work, and I think our therapy colleagues will think the same way too, but at least as surgeons, as soon as somebody starts talking, your job is to hone in on a diagnosis and come up with a plan. And oftentimes it is those first few sentences that give it away. And then the temptation is, and the studies always show that a physician interrupts somebody within the first 30 seconds or whatever. Because I kind of know what's going on pretty quickly. For the most part, I kind of want to move on to my exam and all this stuff. And it's like, really taking the time, and even if it is an extra 20 seconds, just making people listening first and foremost, but then also making people feel heard and listened to. That's a total art. And I think the tricky part about our patient clinic encounters is that there's such a high bar that we need to meet in such a relatively short amount of time. And honestly, as hand surgeons, we don't need that much time. So yes, we're overscheduled because honestly, you don't need a ton of time with most patients, at least at that initial part. And then it is trying to get that personal touch of understanding their goals, setting expectations, coming up with a mutually agreeable plan. Although typically for most surgeons, we're kind of steering that conversation.
All really well said. The one other point, which I know you will agree with, is that you don't, at some point, sometimes you have to stand up and bring things to a close. And that doesn't honestly happen very often, but for whatever reason, and I really try to ask patients at the end of each visit, and I brought this up with my son who had a medical school encounter a planned patient encounter, and the feedback he got was, you did great. The only thing you didn't do is ask me if I had any questions. And I said to him, I don't ever say it that way. I don't ever say it with my hand on the doorknob. I always say seated, what questions do you have? Not, do you have any questions? And that's a subtle difference, but it is a very different statement that patients hear.
I guess I learned it from you, because I kind of do the same thing. I say, what else can what can I answer for you? Because if you ask, do you have any questions? It's a binary kind of closed question, closed-ended, answer. But if you leave it open, I think it helps a little bit. And again, you can't do it on the way out. Although sometimes I really want to be out of there, to be honest with you.
It's true. It's true. All right. What to say? So this
Wait,
is
hold on. Before
Okay.
we move on to that, why don't we thank our sponsors at Checkpoint? And I will let you read the first part so you don't have to pronounce the thing in the second part.
You know my challenges. The Upper Hand is sponsored by Checkpoint Surgical, a provider of innovative solutions for peripheral nerve surgery. Checkpoint Surgical is most known for their intraoperative nerve stimulators, but did you know that they offer a full portfolio of nerve care products to help improve patient outcomes, including a novel biomaterial called NeuroShield?
NeuroShield is a chitosan polysaccharide membrane used for the repair of peripheral nerve injuries by providing a neuroprotective barrier during tissue healing. To learn more about NeuroShield, visit www.checkpointsurgical.com. Checkpoint Surgical, driving innovation in nerve surgery. Now,
What
when
was
the
that
when the
word?
copy when the marketing team sent that over, I actually asked, I was like, you got to cut this down. It's kind of a mouthful. So at least we only got to one kind of hard word to pronounce.
Thank you. You saved me. I would have made a complete ass of myself.
Becca's gonna laugh when she hears this, but
All right. So what to say, and then I have a what to not say section. And this is interesting because I think I like to emphasize to patients, and perhaps it's more to certain patients in the recovery, whether it's post-operative or whatever. I like to remind people when they are doing well. Now, if they're not doing well, I don't tell them you're doing well, but I often just say the simple line, I'm glad you're doing so well. And patients, I think they have intrinsic expectations. Of course they do. We have the benefit of seeing lots of patients with a particular, injury or malady or whatever. And so I think I can honestly say that. And sometimes it's important for patients to hear. Do you do that?
yeah, I think so. I mean, especially with the usually for fractures, it's pretty consistent where people should be afterwards. Oftentimes our therapy colleagues will give us a sense of where people are. So I think it's good to get a sense of that if you can from notes or from, updates from the therapist. For nerve, it's trickier, and patients have no idea what they're supposed to be, where they're supposed to be. So having something grounding them saying you're doing okay, or don't worry, it's way too early to expect to see anything. I'm doing these exams mainly so I can just check, but I wouldn't expect to see anything for another so and so months. And reminding them like that's actually whatever's going on right now is good. Like if they're having the change in their pain, or they're having cramping in their muscles just in the nerve kind of space, like these are good things, so don't be alarmed. And actually you're able to turn that around and message that in a way that is encouraging. But yeah, absolutely, I think it's helpful to provide updates to patients on kind of where they're supposed to be, because they have no idea in terms of what to expect, unless they've had, for example, like a contralateral surgery, like they've already had one cubital tunnel surgery, so they know what to expect for the other side.
Yeah. And the classic one for me is distal radius. The distal radius can be solidly healed and they still have ulnar sided wrist pain. So we have to remind them of what that means. The challenge with bilateral staged surgeries is the two
Never the
sides,
same.
they're never the
Never the same.
same.
And I tell people that, like when I see them holding, like, look, you kind of know what to expect here. I will tell you, no patient has ever had the same experience on both sides.
Yeah. And I always add, I hope that this side's a little easier than the last, but it might not be. All right. The next one, and I know that you and I agree on this, I feel really strongly, and the longer I do this job, the more strongly I feel, is I essentially say something like, my job is to outline your treatment options. It's not to tell you what to do. Of course, we as physicians can say things how we want, but I think that's important. I don't, unless a patient says, Doc, what would you do? What would you do if I was in your family? What would you do if this was your kid? I will answer those questions, but I just try to give patients options.
Yeah, I remember Dan would say when he was still on faculty here at WashU, I remember seeing patients with him when he was still relatively early in practice. And I was like, well, why did you say it this way? He's like, look, I give them the options. You give them the menu, and I think that some patients, most patients like that, but there are still some patients who say, "Doc, what would you do? You're the doctor. I'll do whatever you want." And how do you approach that? Do you truly think about it from what you would want, or from what you think is best? Are you still paternalistic in terms of what you think this patient would want from your likely very limited interaction with them?
Yeah, I think in many situations that's not hard, and I do have an opinion. But if if I either don't know enough, then I'll ask questions, or if I just don't know that there is a right or wrong choice, I'll say that. I don't mind giving my opinion. I certainly will give my opinion. But if I don't have an opinion, um, I'm honest about that. I might say I might not do options 3 or 4, but 1 and 2 are, whether it's a cubital tunnel decompression or transposition, there's pros and cons, and here's what they are. And I think ultimately you have to choose what makes sense for you.
I think it's so tricky to try to put yourself in patient's shoes. I think that's where the listening part comes in. And in terms of, at least for fractures and stuff, it tends to be a little more straightforward in terms of how they hurt themselves and what their eventual goals are and the timeline for those goals. If somebody hurts themselves playing pickleball and they want to get back to playing pickleball right away, even if they're a little bit older, I may really consider fixing their distal radius fracture, because that's an active person that wants to get back to doing active things. And that makes me think like, all right, this is somebody who probably would benefit from surgery more than somebody else. But then you look at some of the more elective type, things like you're saying, cubital tunnel surgery. I think everybody's appetite for risk is different, and trying to understand somebody's risk calculus is very, very challenging in the limited interactions we have.
That's challenging, and understanding or predicting pain is challenging. And I'm upfront about both of those, right? I don't try to predict pain. I explain that to patients, but that's exactly right. I see it the same way.
Like,
I
yeah,
have
just I guess one more thing, like along those lines, like one example is that like for a stable ulnar nerve, but somebody who has cubital tunnel symptoms that has had has tried non-operative measures and still has persistent symptoms, your risk of having a second surgery after an in situ cubital tunnel decompression is probably somewhere between 7 to 20%. But it's a much quicker recovery. And so it is like, well, do you just want one surgery to be done forever, but have a longer recovery, versus there's a chance you're going to need a second surgery, even though patients who have a second surgery may not do as well. So it's a little bit more nuanced. I mean, that's the kind of quick decision that we have to make in clinic when somebody asks us, what would you do if it was you, or what would you do for me?
Yeah, going totally on the wrong direction on this. The more I do transpositions, especially subcutaneous with a fasciocutaneous flap, the more I think the recovery is not bad, and patients tend to fly through it. Another episode. Um,
Yes.
my last what to say is, I say something along the lines of, look, I can't look you in the eye and promise that this surgery that we've discussed will cure you. I just don't know that. But what I do know is that I wouldn't offer this as an option for you unless I thought it had a reasonable chance to be helpful. Do you
Yeah,
see anything?
I totally agree with that. And again, we're going to get in trouble for agreeing with each other too much here, but I think it is kind of a personality thing, in terms of how we approach these interactions. But, I wouldn't offer them something that I don't think would help them. So I think that, you do kind of make these quick decisions as you quickly get to know somebody. And if it doesn't make sense for them to have surgery, even though their X-ray and their textbook, the indications are textbook, say, look, I don't think you should have this done. And I think it is very, very powerful, or at least it should be, when a surgeon tells you that you should not have surgery. I don't know if it's true in the reverse, but if somebody tells you, who makes a living doing something, tells you shouldn't have surgery, that I think is very influential.
And I say it, I'm sure you do too. I say it. I say, look, I'm a surgeon. I make my living doing surgery. I don't think you benefit from having surgery. I hope you understand that I'm just giving you my honest opinion. And for some patients, they need to hear that. For some patients, it's still not enough.
Right. And I think there are a lot of different ways to approach it. I think one of our other partners is very much, more paternalistic the longer that they practice, in terms of, kind of saying, look, this is what I think you should do. And you're wrong if you're not going to do what I want. And I get that too, because oftentimes patients don't know what they don't know. And we do have so much a bigger wealth of knowledge than so many other people, in terms of, what we understand and how we predict how somebody's going to do. So I can totally see how, if that is not the right approach for some of our listeners too.
Yeah, exactly. Um, There's two words I don't like to say. And the first is maybe stimulated by my wife. I don't like the word fine. I actually looked it up, and fine can, if you look it up in the dictionary, it can mean really good, extraordinary even. But I don't think that's the modern day connotation. I think fine means okay. So I often catch myself after surgery. I'll go talk to the patient and the family. I'll say, your surgery went fine. And then I'll actually stop and I'll correct myself and say, look, I don't like that word. Your surgery went as well as we could have expected, or went perfectly. But fine to me is a level below. So I don't use that word anymore.
As one of my mentors in residency would say, and John Healy always had these kind of seemingly off the cuff and incredibly profound sayings, probably because we were in clinic until like 11 p.m. But it was words have meanings, meanings have words, use them both appropriately. And that just stuck with me. And I think it definitely matters the language that you use. And I think that the precision in which we use that language is super important.
Yeah. And the other one is fix. Now, I'm from Alabama, so sometimes I might have said
You're
I'm
fixing to finish this podcast.
and I am, but that's not what I mean. But again, my wife, she hates fixing, she hates might, should, might, could. I know I've said that, but no, I don't like it when, and I usually don't say it, but patients will say it back to me. And so I was in a conversation last week and I said, we're going to, repair your distal radius fracture. And they said, well, when you fix my distal radius fracture, and I said, I don't love that word. And here's why. I don't love that word because it implies like closing a door. You're going to fix it. It's done. Move on. Everyone's happy, lives happily ever after. It's just too final for me. So I don't use the word fix.
Yeah, I think along those lines, one word I will not say, or I will correct patients if they bring it up, is perfect or same, because it's never perfect or the same after an injury or after a surgery. And I think that is somewhere, if you, especially for, again, getting to my space of nerve, if you message things correctly from the beginning about how this will not be the same as it was before, it will not be perfect, it won't be the same as the other side, that is such a critical part of the messaging to get done at the beginning, and you have to do it delicately because you don't want to deflate hope. So it is all about how you say these things and how you put together the sentences in the encounter, and then repeating that messaging over time, because oftentimes they stop listening to you because you've told them some other thing that's kind of devastating.
No, that's exactly right. My last one, and you and I could have this conversation forever, and maybe we should do a follow-up episode at some point. But when patients ask, for me, there's so many athletes in my clinic, and it's always, when can I get back to play? And it's just another thing you cannot promise. You can give your estimate, and parents hear what they want to hear, especially with the adolescent elite athlete. Trainers hear what they want to hear, and agents hear what they want to hear. So I think we have to be very specific and always err a little bit on the long side, because you look good when you get them back faster. You don't look good if it takes them longer. So everyone's different. The recovery will look different. There's things we can't anticipate. So I am purposefully a little vague, but not intentionally prolonging things, but just a little vague.
Yeah, no, I agree with that. And I think that, getting back to your point about, patients don't quite have the compass that we have. And then the reverse of what you're saying is that patients oftentimes will not use their extremity as much as they probably can or should, because for fear of hurting themselves or hurting what we help them accomplish with surgery. And I think to close, I think one of the things that I picked up from Marty was the saying, "You won't hurt it; it might hurt you." In terms of recovery for something as simple and not simple. Simple is also another word I don't like to use. Straightforward as, carpal tunnel or a trigger release.
Oh, well said. And I agree with both of those. Simple is not appropriate. In fact, I call syndactyly either cutaneous or complex. Some people use the term simple for syndactyly. There is nothing simple about syndactyly. So that's a great point. Yeah, and I also use that. It's funny, when Marty was giving this talk, I use some of the expressions so often, I think they're mine. And so I wonder whether he stole them from me, but most likely I stole them from him. It doesn't matter, but it might hurt you, but you're not going to hurt it is a really good one.
All right. Well, this was fun. Hopefully, our listeners, whether you're a therapist, surgeon, resident, medical student, fellow, you've picked up something that you can use. And please feel free to tell us if you have some insights or you vehemently disagree with anything that we've said. So handpodcast@gmail.com.
Yeah, we would love to hear your thoughts or your sayings or your not sayings would be awesome. And again, maybe there's another episode here, but super fun, learned as always, and have a good day.
You too.